Hello everybody, this is Dr. Patel again. Today we are going to talk about approach to antibiotic uses, part 2. In the first part we talked about general approach to antibiotic uses. In this part we'll be talking about a specific antibiotic in specific infections. Let's dive into it. So let's start with skin or soft tissue infections, which are classified based upon presence of pus. Uh, Infection with pus are called purulent cellulitis. Infection without pus are called non-purulent cellulitis, and they are also classified based upon severity. They are classified as mild, moderate, or severe disease. Somebody with systemic signs, those are considered moderate disease, and somebody who have sepsis, who have failed treatment, or somebody who is immunocompromised, those folks are considered to have a severe disease. So let's talk a little bit about staph and streptococcal infections. Staph secretes coagulase. What coagulase does, it changes fibrinogen into fibrin, and what fibrin does, it walls off the area, and the bacteria does intense damage in that localized area, resulting in necrosis of the tissue, and it results in the formation of the pus. So staph aureus infection, classically they are pus forming. On the other hand, streptococcal infection are spreading in nature. Streptococcus, secretes streptokinase and hyaluronidase, which actually dissolves those fibrin strand and results in spreading type of infection. So that is a basic difference between streptococcal and staphylococcal infection. So when you look into this slide over here, treatment of purulent cellulitis primarily revolves around draining that pus. Whenever there is a pus in the body, that needs to come out. If it is in the accessible side of the body, you do incision and drainage, and if it is in the body cavities, you have to aspirate or you have to drain that pus. If you don't do that, basically, even if you give antibiotics, that antibiotic is not going to work in that pus. So that is the first principle. And then as you can see here, the treatment of purulent cellulitis in the mild disease, incision and drainage is sufficient. We'll be talking about that in the future slide. And then in moderate disease, by empiric treatment, trimethoprim sulfa and doxy, and then definitive treatment consists of dicloxacillin and cephalexin. If your patient is obese and you have concern about adequate tissue level not being obtained, you can consider IV in those folks. And then what are the MRSA risk factors? So MRSA risk factors, somebody with a nasal colonization, or somebody who had a MRSA infection in the past, or somebody who has been to the hospital in the last 90 days, or somebody who has been treated with the recent antibiotics. So those are the folks who are at risk of MRSA infection. And as you can see here, severe disease, again, you do IND, empiric treatment consists of coverage for MRSA, and then definitive treatment is based upon culture and sensitivity report. And then non-purulent cellulitis, there is no pus. So basically, the primary treatment is going to be antibiotics. And remember, most of the streptococcus are still sensitive to penicillin, so you'd like to choose, penicillin group whenever you can. As you can see, anything beyond moderate non-purulent, MSSA coverage is given. Somebody with a severe disease, including penetrating trauma or history of MRSA infection elsewhere, or nasal MRSA or IV drug uses, those people you may want to give MRSA coverage. And as you can see, their surgery is done in the severe disease for culture and sensitivity, because you want to know what antibiotic is going to work. And then typically those severe cellulitis patient we treat with the vancomycin and Gelson. So let's go to the next slide. Remember, not all rivers are sepsis. misdiagnosis of non-infectious conditions like venous stasis and dermatitis, trauma-related inflammation, DVT, or thrombophlebitis is pretty common. So whenever you have a patient with bilateral leg redness, most likely it's not a cellulitis. We already talked about difference between purulent and non-purulent cellulitis. Purulent cellulitis, presence of pus, typically caused by staph, and then not always you need antibiotics. On the other hand, non-purulent cellulitis, which is typically caused by streptococcus, and most of the time you treat with antibiotics. Remember, most streptococcus are still sensitive to penicillin. And then up to 10 to 20% of these streptococcus are now resistant to clindamycin. So remember that when you are choosing antibiotics. Do you need gram-negative coverage? Answer is no. Gram-negative organisms, they don't cause cellulitis most of the time if your host is normal host. Even in the diabetics, gram-negative coverage is not always needed. What is the indication of gram-negative coverage in cellulitis? If your patient is immunocompromised patient, if there is a concern about necrotizing infection, if it is an infected diabetic ulcer, especially if your patient has been obsessive about washing their feet, and then remember, Pseudomonas loves the moisture. So those diabetic ulcers, especially if your patient has been obsessive, about washing those diabetic ulcers several times a day, those ulcers might be colonized with the Pseudomonas. So remember that. Perirectal infections, bites, aquatic injury, or severe surgical site infection involving groin or abdominal wall. So these are the indication for gram-negative coverage. And then how long to treat for? 5 to 7 days course should work for the most. And then by day 3, the patient should be improving, and then most can be changed to oral by day 3, because we should have some information by day 3. Treatment duration. So when we were talking about treatment duration, there was a randomized control trial published in JAMA 2004. They compared between 5 days versus 10 days of therapy with a levofloxacin, and they excluded severe infection. It was just uncomplicated cellulitis. So that means people with bacteremia, people with severe sepsis, deep infection, bites, or infection requiring debridement, or diabetic foot infection, those are excluded. So in those population, what they found, there was no difference in outcome when they compared between 5 days versus 10 days course. Though the study was done in fluoroquinolone, we can probably generalize this information to other antibiotic as well. And another very important observational finding that was documented in a study in Clinical Infectious Disease 2016, what they found was any increase in size of margin of erythema is not necessarily indicative of antibiotic failure. When you start your patient on antibiotics, in first 48 hours to 72 hours, the size of erythema can actually increase. Because when you kill bacteria, they release toxin. The toxin release can cause extensive local inflammation, can actually increase the inflammation. So that increase in the size or lack of change in the size does not really tell you that your antibiotic is not working. Very important principle to understand. Let's go to the next slide. Rapidly progressive cellulitis, you see with the group A streptococcus classical patient, patient with a lymphatic disease, either status post cabbage or status post mastectomy, pasteurella multisida with animal bites, Clostridium perfringens with a wart trauma, Vibrio vulnificus. Classical patient is cirrhotics, playing golf in the coastal area, and then having exposure to seawater, and then getting Vibrio vulnificus from the seawater, and then since they are cirrhotic, they don't have complement, they tend to have fulminant disease with the Vibrio vulnificus. Necrotizing fasciitis is very important diagnosis that you should not be missing. Necrotizing fasciitis is a misnomer. There is no predominant necrosis of fascia. Necrosis is predominantly in the muscle. Fascia are actually relatively spared. Very important principle is these are the deep infections. So when you look at the wound, it does not look that bad. It looks dusky blue, and there might not be significant erythema there since it is deeply situated. So if you see here in the picture, see how deep is the necrotizing fasciitis. So here, so you don't see a redness from outside. So it's very close to muscle, and then basically they might have skin necrosis or blebs. They complain of disproportionate pain. Um, so the wound does not look bad, but they have very severe pain. And then all of a sudden, when they lose pain, that's not a good sign. Why they lose pain? That means their nerve are dead. So that's why they are not feeling anything. So and then they have disproportionate systemic toxicity. And then when you do x-ray, you see gas. When you feel crepitus. So whenever you see these findings, you need to think about necrotizing fasciitis because it's a medical emergency, and you have to have early surgical consult, and you have to give big guns to antibiotics to this patient, covering MRSA, covering gram-negative, and covering anaerobic. And addition of clindamycin to these people has been shown to improve the outcome. Clindamycin is a protein synthesis inhibitor, and clindamycin inhibits some of the proteins that actually causes this necrotizing fasciitis. Um, and that's about necrotizing fasciitis. So let's talk about antibiotic in uncomplicated skin abscess. So classical teaching had been not giving antibiotic to skin abscesses. Then came this study published in NEJM 2016. What they did, they look at uncomplicated abscess, IND in the ED, and then they compared between Bactrim versus um, placebo for 7 days. What they found was the cure rate, as you can see here, was better with antibiotics, 92 versus 85. Then the need for repeat IND was more with the placebo. So there was a benefit in the patient. The benefit was not limited to patient themselves. It was also seen in the household contacts. So up to 4% of the people who were not treated with antibiotics, they had infection in the household members. So after this study, we started treating uncomplicated abscess with short course of antibiotic. So in terms of choice, what to choose, they compared between clindamycin and Bactrim and placebo, and then they look at the outcome at 10 days, 1 month, and they also look at the adverse reaction. What they found, compared to placebo, both antibiotics were effective. And when they compared between clindamycin and trimethoprim sulfa, clindamycin had more side effect. So after this study, we started choosing more Bactrim or doxycycline rather than clindamycin when it was small skin abscesses. Remember, clindamycin has some resistance, development of resistance to streptococcus as well. So, which is really interesting finding. So that we should not be giving clindamycin to everybody. Then do we need to treat with two antibiotics? The answer is no. There was no additional benefit with a combination of cephalexin and Bactrim compared to cephalexin alone. So we just give one antibiotics. So let's talk about bacterial meningitis. Somebody comes to the hospital with fever and altered mental status. So first thing first, you stabilize the patient, you send for blood culture, and then you are going to ask your patient about these 7 factors. And is your patient 60 years or old? Is your patient immunocompromised? Does your patient have a CNS disease, or had a seizure in last 1 week, or papilledema, or focal neurological deficit, ultimate status? So any of those factors are positive, then you need to get image. You need to get CT scan or MRI before lumbar puncture. If those are negative, then you can get lumbar puncture. You send for cell count, culture, and chemistry. Chemistry consists of glucose and protein, and then you continue empiric antibiotic while awaiting the culture report. And then as soon as you do lumbar puncture, you start on dexamethasone 10 milligram and you continue that Q6 hours, and typically given just before antibiotics, and then you give empiric antibiotic based upon age and the risk factor. So these are the antibiotics that you are going to choose for different kind of infections. You can see here, and then um, if your culture comes back negative for pneumococcus, then you are going to stop dexamethasone. Otherwise, you are going to continue. If it comes positive for pneumococcus, then you continue that for a total of 5 days, because only with the pneumococcus, dexamethasone has been shown to decrease cranial nerve palsies. So that's why we continue dexamethasone in that specific instance. So next we are going to talk about urinary tract infection. So let's start with the case. 44 female with a history of bipolar disorder presented with suicidal ideation and admitted in the psych floor. And you are consulted by psych service to evaluate for UTI. She denies any fever, chills, urinary frequency, or abdominal pain. Physical examination was normal. Labs value mild leukocytosis. BMP is normal. Positive for cocaine, cannabinoids, pH 5.5, leukocyte ester positive, nitrates positive, and then bacteria plus WBC 25, and urine culture grew 10 to the power 5, E. coli, pregnancy test is negative. So what are you going to recommend to psych service? Treat with Bactrim for 3 days, levofloxacin, nitrofurantoin, fosfomycin. No treatment at this time. So this patient does not have any fever, chills, urinary frequency, abdominal pain, and does not have any symptoms. So asymptomatic, but has a bacteria in the urine, is confirmed by the culture. So it is asymptomatic bacteriuria, and this lady is not pregnant, so you should not be treating this patient with antibiotics. So asymptomatic bacteriuria you treat only if your patient is pregnant, if your patient is going for a urological procedure with bleeding, or if patient had a renal transplant less than 3 months back. Otherwise, you should not be treating these people. Why in a renal transplant? If you don't treat renal transplant, there is a more rejection in this population. Especially in the first 3 months. And in all these cases, you treat with fluoroquinolone 3 days, except in the pregnancy, where you treat with 3 days of trimethoprim sulfa from 12 to 36 weeks. And then if it is in other time, then you use either nitrofurantoin or cephalexin, because you cannot give Bactrim in the first trimester or in the last trimester, or around the time of delivery. So whenever you have a patient with a UTI, the first thing first, you are going to determine whether it's upper UTI or lower UTI. Upper UTI, people have a systemic symptoms. They have a fever, chills, or flank pain. So they have systemic symptoms. On the other hand, cystitis, they just have a burning urination. They don't have flank pain. They don't have a fever. So that is first thing to do. And then you need to determine complication. So what makes your patient complicated? Remember these 6 factors. So, and always remember before you answer question on the board. So diabetes or immunocompromised, somebody with a structural disease, somebody with a duplication of ureter, or somebody with horseshoe kidney, or abnormal physiology, something like vesicoureteral reflux, or somebody with a foreign body, somebody with stones, or somebody with a resistant organism, and male is conventionally and classically considered complicated UTI. So whenever you have complicated, you treat with, if it is a cystitis, you treat for 7 days with Bactrim versus 3 days on complicated. So that is the difference there. And also complicated um, 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 and uncomplicated in terms of pyelonephritis. If you see here, trimethoprim sulfa 14 days um, versus fluoroquinolone for 7 days. So if you are treating the fluoroquinolone 7 days versus Bactrim 14 days when you're treating pyelonephritis. And remember, don't use Bactrim if local resistant rate is more than 20%. So that's the reason why you have to eat ceftriaxone or gentamicin times 1 when somebody presents with pyelonephritis until you have your culture report back. Remember not to use nitrofurantoin in pyelonephritis and also fosfomycin in pyelonephritis, because to treat pyelonephritis you need blood level in addition to urine level. These both antibiotic, they achieve urine level but they don't achieve blood level, so you cannot use these two antibiotic. Remember nitrofurantoin and fosfomycin to treat pyelonephritis. So let's talk about pneumonia. So community-acquired pneumonia. So somebody presenting with the sign and symptoms of community-acquired pneumonia. Um, somebody with a fever and cough. So you send chest X-ray in selected people. You do chest X-ray. You send sputum and blood cultures, and then you risk assess by by the use of port or with the use of curve 65. Either is fine. Then basically based upon that score, you determine where they belong to. Somebody with two in a curve, they need to be admitted. Somebody with 3 or more, they go to ICU. So this scoring system really helps you to dispose your patient, and really important when you are working in the emergency. Then for outpatient treatment, you ask yourself question, what is the risk of resistant streptococcal pneumonia infection in your patient? If answer is yes, you start levofloxacin or you combine amoxicillin with azithromycin. If answer is no, you give doxycycline or azithromycin. So what are the risk of resistant streptococcal pneumonia? So is an antibiotic in the last 3 months, exposure to child in daycare, medical comorbidity, which has been listed over here. Let's go to the next slide. So inpatient non-ICU treatment. So how do you treat? So if your patient is admitted non-ICU, so basically you use either levofloxacin or you combine ceftriaxone with azithromycin. Um, so rather than azithromycin, you may want to use doxycycline if your patient has a prolonged QT, in which case you cannot either use levofloxacin or you cannot use azithromycin. So in that case, what do? You combine ceftriaxone with a doxycycline. So if your patient received antibiotic recently, ertapenem is the choice. And then inpatient ICU treatment and at the risk of pseudomonas. Who are the people at risk of pseudomonas? Severe structural lung disease, something like bronchiectasis, or somebody with a bad COPD who is on oxygen, or recent antibiotic users, or somebody who had a recent hospitalization. So these are the risk factor for pseudomonas. And then if there is a risk factor for pseudomonas, you may want to cover a double gram negative. So typically you give either um, piperacillin tazobactam with a levofloxacin, or you give piperacillin tazobactam azithromycin plus gentamicin, or you can also give Josin, which is piperacillin tazobactam with levofloxacin with gentamicin. So either is fine. So the whole idea is to cover double gram negative, and out of that gram negative coverage, one has to penetrate to the lung. So piperacillin tazobactam can do that. You can substitute piperacillin tazobactam with cefepime as well. And then if there is no risk for Pseudomonas, you treat like you did in the non-ICU treatment here with ceftriaxone and azithromycin or levofloxacin. So let's talk about next case, 38-year-old male with history of opioid use disorder, admitted for fever and low back pain. And then MRI reveals IL-2 to 3 decitis and epidural fragment and with cord compression. So blood cultures are pending. So what do you want to choose for empiric antibiotics? So the cord compression, so make sure you call neurosurgery right away. And then regarding antibiotics, vancomycin and ceftriaxone. So what about cefepime? Cefepime could have been a reasonable choice as well, especially if you have a concern for Pseudomonas. Especially this patient who is IV drug. If patient has IV drug abuse history, which is not clear here, cefepime would have been a reasonable choice. So vancomycin and cefepime both are started, and then you wait for the culture report, and then look here, oxacillin resistant. So what is that? That is MRSA. So turns out to be MRSA. So ceftriaxone was stopped, discontinued on IV vancomycin. Then neurosurgery did operative debridement for source control, and then patient was given IV vancomycin for a total of 6 weeks per IDE recommendation. So let's talk about C. diff infection. So we used to call Clostridium difficile infection. Now they changed the name Clostridioides difficile infection. Gram-positive spore-forming anaerobic bacillus. So disease if toxigenic strain is ingested by susceptible person. So you need both. You need toxigenic strain. You need susceptible person. Fecal-oral transmission. But remember, non-poopers are important source of potential infection to other. Remember that. So somebody without symptoms are actually the important source of infection. And toxigenic strain are the one that make toxin B, which is a cytotoxin, with or without toxin A, which is an enterotoxin. So why it is important to treat C. diff infection and even learn about C. diff infection, because 30-day mortality in healthcare associated cases in patient more than 65 is almost 12%. So all-cause 30-day mortality in a recent Canadian study was 13.4%, and out of that 4.4 was directly attributable to C. diff infection, which you compare with a STEMI, that is myocardial infarction, ST elevation MI, 4.3%. So that's why it's very important to understand how bad is C. diff infection. So if somebody has AMI, you will be really scared. I don't think C. diff diagnosis triggers the same amount of fear. So we provider need to educate our patient. So risk factor antibiotics, and there was an interesting study. What they found, sleeping in a bed previously occupied by a patient who received antibiotic is also a risk factor for C. diff infection. PPI, GI manipulation, advanced age, comorbid conditions, malnutrition, inflammatory bowel disease, and interestingly, benzodiazepines and gabapentin has been described as one of the risk factor. And there was a case control study involving almost 200,000 people with a C. diff infection. What they found was 4.8%, around 5% had a household contact with C. diff within last 60 days. So this study was kind of eye-opener. So always make sure you counsel your patient when you are discharging your patient with C. diff home. Make sure to counsel on recommendation about how to wash hand and how to disinfect bathroom or kitchen, because their family members are at risk of C. diff infection. Healthy individuals, 1 to 2%, colonized with C. diff. They have very low risk of developing C. diff infection. Antimicrobial exposure is the major risk factor. And then um, out of antibiotics, some antibiotics are very likely to result in um, C. diff infection, like clindamycin, ampicillin, amoxicillin, cephalosporins. On the other hand, tetracycline, metronidazole, vancomycin, and parenteral aminoglycoside, they're rare to neighbor. They never have, um, result in C. diff infection. And as you can see here on the right side, more the duration of antibiotic uses, more chance of you getting C. diff infection. And another factor is immunostatus. So basically, people with immunodeficiency, they are at risk of developing C. diff infection, and when they develop, they are likely to get severe disease. So talking about typical presentation, acute watery diarrhea, it might be bloody in up to 5% people. They also present with lower abdominal pain, low-grade fever, or leukocytosis. If your patient is in the hospital and then is having, progressive leukocytosis and looks reasonably well in appearance, so think about C. diff infection, especially if you have other C. diff patient, or if your patient is on antibiotics. Pseudomembranes might form in up to 50% people, and 1 to 3% people get severe disease. Remember, out of total colectomy cases, 5% is actually contributed by C. diff infection. So it's um, very important infection to treat. Some people they also get reactive arthritis. Severe colitis is classically seen in people with malignancy, ESRD, somebody with immunosuppressive therapy, and very importantly, people who are getting antiperistaltic medications or even clindamycin. So never ever give antiperistaltic medication or antidiarrheals in C. diff until actually you rule C. diff out. That's very, very important part of management. C. diff infection recurs in up to 20%, and in subset of those folks with recurrence, it spirals into several subsequent recurrences. So how do you diagnose? So never test on solid stools, or never test on asymptomatic patient, or those on laxative. It doesn't make sense to give a laxative to have a bowel movement and then you check for C. diff after you give laxative. So so test only diarrheal stool. So what are the diarrheal stool? The stool that assumes the shape of container, that is a diarrheal stool. So in terms of study, you do GDH, which is glutamate dehydrogenase or toxic immune assay. So GDH is 90% sensitive, but 20% false positive. On the other hand, toxin immune assay is fast, it's cheap, but it's not sensitive, just 50%. So you do both. If both are positive, then your patient has C. diff infection. If only one is positive, then you do PCR. PCR is not done first. Why it's not done first? It's rapid, it's sensitive, 93 to 97, but it's expensive. That's why we don't do it first. So if one is positive, you do PCR, and once that is positive, then your patient has C. diff infection. Talking about treatment, oral vancomycin is the first line for all form of disease, mild, moderate, severe, because success rate is 81% versus 73% of metronidazole. And also discontinuation rate is low with the vancomycin, just 6% versus 12% of metronidazole. For fulminant, you give PO vancomycin and IV metronidazole, but non-fulminant you cannot, guideline does not support the use of combination. Vancomycin can substitute PO vancomycin if your patient has ileus, and there is a concern that PO vancomycin is not reaching the site of infection. Consider surgery consult sooner than later. First relapse, you do oral vancomycin taper or fidaxomicin. 2 or more relapses, you do fecal bacteriotherapy. Which is also called fecal transplantation. So there are 3 approach: colonoscopy, and then enema or frozen capsule. So 3 ways to do fecal bacteriotherapy. So you do that when you have 2 or more relapses. Then there are new options: rifaximin tail or ursodiol for somebody with a relapse. And then there was a new study published in Clinical Infectious Disease 2020. What they found was vancomycin 125 once a day while being on antibiotic, and then you continue that 5 days after they are done with other antibiotics. So that approach resulted in decrease in relapses, and there was 0 relapses versus 6 relapses in the placebo. So vancomycin taper has been stated over there. You can look into there. And then bezlotoxumab. So basically monoclonal antibody to toxin B. It was approved in 2016. Recurrence rate is 17% with usual case versus bezlotoxumab versus 28% with the usual care and placebo. So there was a improvement outcome with this monoclonal antibody. What about the surgical innovations? So the surgery in C. diff is going to be radical colectomy. So what they did was they tried loop ileostomy with colonic vancomycin lavage for fulminant C. diff, and what they found: 26 mortality versus 31% mortality from total colectomy, and then only 14% required conversion to total colectomy. So after this study, we started doing this loop ileostomy. So calling surgery, in severe disease is considered when your patient has severe disease. So let's talk about fidaxomicin and rifaximin. So basically, fidaxomicin versus vancomycin, they compared. They found fidaxomicin is better with a lower relapse, just with 13% versus 24%, and both of them had a equal or similar cure rate. And then there was a study where they found use of rifaximin tail to prevent relapse. They found it to be beneficial. They also did another trial, which you can see here, Extend trial 2018. They did fidaxomicin 200 BID for day 1 to day 5, and then they did 200 every other day from day 7 to 25 versus vancomycin QID for 10 days, and they found 70% sustained cure with fidaxomicin versus conventional vancomycin. But the issue with the fidaxomicin is neutropenia, GI bleed, and high electives, in addition to being costly. It also causes hyperuricemia. And these are my references. Thanks for watching. And this is my email. If you have any questions, feel free to email me. Thank you so much.